A quote I heard from Paul Batalden, who's a pediatrician at Dartmouth, one of the fathers of the patient safety movement. He has said that every system is perfectly designed to achieve the results it gets. Our incidents, whether they eventually turn into filed suits or whether they just reside within that bucket we call claims, that are demands for payment, that someone has asked us to give them money because they didn't like the result or the experience they had. Those incidents are the outputs of processes that we deal with on an everyday basis. And so one of the opportunities I think we have is to reduce our risk by understanding our processes and using a framework for problem solving that allows us to organize our thoughts and approach it in a very disciplined way. So one of the things we have heard very popular right now, I know a lot of our clients have had experience with it. A lot of hospital systems are deploying Lean as their management methodology, Lean being an offshoot of the Toyota production system. Set of philosophies, tools, and principles that are simple. They're easy to teach. We have good documented evidence that it is effective or can be effective. A couple of recent reviews in annals of worldwide application of Lean principles in emergency departments and understanding how the use of those tools has made improvements in their organizations. So one of the advantages of using Lean is simply that it's easy to teach. It can be used by people at all levels of the organization. One of the challenges, however, is how do you do that in your department alone when the rest of the organization hasn't bought into it? Because the application of Lean principles is really a cultural phenomenon. It must start from the top in the organization, and it must be accompanied by organization-wide analysis of how patients or how the products you build and deliver are delivered. For us to look at the problem of boarding as an emergency department problem without looking at the entire flow of patients from door to door. And when you break it down, the boarding problem is about medicine patients stuck on the floors and having long lengths of stay. And all of that delay in the care that is being delivered there backs up and causes bottlenecks in the emergency department. I'm not suggesting we don't own a piece of it. But so now we have a challenge. If the organization, the hospital organization, is not ready to adopt that sort of cultural imperative to look at the whole value stream, how do we still fix the things that we do? So let me give you an example. I had the chance to work with a group of physicians who are interested in improving flow of patients through their practice. And I watched their work and I did some sort of overview analysis of their workflow. And I presented them with two problems. The first one was, I have a 2-year-old with a fever and ataxia, tell me what you would do. And all 4 of them right away, boom, they could give me the answer. And they were in agreement immediately. I said, okay, here's the second problem. That child waited 3 hours in your waiting room before they got to an exam room for you to see them. What would you do about that? And their response was, well, you know, that's really administration's problem. I said, no, that's really your problem. And so in the conversation, I said to them, what if we were to take the same discipline around how you solve that clinical problem and applied it to a business problem? And we can build on the same sequence of events that you use to take care of a patient and apply that to flow of your patients through your clinic. And so we walked through that scenario. The chief complaint, something that as physicians we're used to starting with, what we have seen in problem solving in hospitals and healthcare organizations, in spite of all these tools we've been handed to improve processes, the predominant problem solving method we see today is a bunch of people sit around a table and the loudest guy wins. That's it. And If we were then able to say, you know, there's a better way to do this, and as clinicians, we already solve problems all day long, every day, and we use a very disciplined approach. Chief complaint, history of present illness, physical examination, some testing, an understanding of the desired future state, and then communication with patient, family members, all the stakeholders who need to know about the treatment. And then we put a treatment plan in place. There's a very defined cycle that we go through. That same methodology can be used to solve problems in the emergency department that are operational issues. You can call it lean, you can call it Six Sigma. I don't really care what it's called. What I do care is that it's problem solving with some discipline. The same kinds of things we would expect our mid-level providers, our medical students, our residents to do. Patient care with discipline. This is business problem solving with discipline. There are a couple of, really four things that contribute to failure of our processes and systems. Number one, the first is systems that are overburdened. Every system that is designed, the system being a collection of processes, every system that's designed was designed for a certain capacity. If that capacity is exceeded, and we know the reasons they're being exceeded, emergency departments are being tasked with more work than ever before, smaller number of emergency departments than ever before, and their systems were not designed to handle that. So the systems are overburdened. There is also the unevenness of demand. If in fact we could have only one kind of patient come in every 15 minutes, we could design an absolutely perfect emergency department. We will have removed the unevenness of demand and the variation in presentations. The third thing that really has a big impact on process redesign is legacy processes. There are so many organizations, when you ask the question, so why did you do it that way? Beats me, it's always been done that way. Well, does it still make any sense? No, but it's always been done that way. And the fourth, and I think most often underestimated impact on the wasteful processes we have, or the processes that give us the results we're not wanting, is the impact of our architecture. It is one of the most important attributes of the design of a department that drives how the systems and processes not only are designed but how they perform. And at the end of the day, it's about how do you solve problems. And if we can take and use a clinical problem-solving model, apply it to business problems, and use new tools, because the physicians, the practitioners oftentimes don't know how to build a swim lane diagram. They don't know how to build a value stream map. Those are the kinds of tools that are in our world, in medicine. That's the equivalent of a laboratory test or a MRI or some diagnostic test we would use. So we have other tools, but the methodology for problem solving can be the same.